Hi, I'm Dr. Neelvardhan Desai. The topic of discussion is point of care ultrasound in critical care and observational study on its role in shock and cardiac arrest decision making. Point of care ultrasound focus has rapidly evolved from diagnostic modality to core component of bedside assessment in critical care medicine. Its ability to provide immediate real-time non-invasive visualization of cardiovascular pulmonary abdophysiology has fundamentally changed the approach to critically ill patient. Shock represents acute circulatory failure, whereas cardiac arrest is an extreme manifestation of circulatory failure and remain leading cause of mortality worldwide despite advancement in resuscitation science. Advanced cardiac life support emphasizes high quality cardiopulmonary resuscitation, early defibrillation, identification of reversible causes summarized as TS or HS. Despite its expanding role, the integration of focus into shock and cardiac arrest management requires structured protocol, operator expertise, and structure adherence to resuscitation principle to avoid interruption in CPR. The aim is to evaluate the role of point of care ultrasound in guiding clinical decision making during management of shock cardiac arrest in critical ill patient. The objective is to utilize focus and identify the underlying etiologies of shock, a reversible cause of cardiac arrest, and its influence on immediate therapeutic intervention during resuscitation in critical care. The study design being prospective observational study, which was done in intensive care unit of Krishna Institute of Medical Science. Duration period of the study is 12 months, and all adult presenting with shock and cardiac arrest during this period were screened. Inclusion criteria is patient aged more than 18 years, patient presenting with undifferentiated shock, patient presenting with in-hospital or emergency department cardiac arrest requiring advanced life support, and patients with whom focus was performed as a part of initial evaluation or resuscitation. Exclusion criteria: patient aged less than 18 years, patient with traumatic cardiac arrest with surgical intervention was immediately prioritized, patients with incomplete ultrasound data or poor imaging acquisition, patient in whom focus could not be performed due to logistic or technical limitation. The sampling size after calculating was 30 patients. Ultrasound examination has integrated routine clinical evaluation and resuscitation without delaying definitive treatment. In patient with shock, a structural approach based was followed, including cardiac assessment for ventricular size, systolic function, pericardial effusion, inferior vena cava assessment for volume status, lung ultrasound for pneumothorax, pleural effusion, and interstitial syndromes. Abdomen scan for free fluid when clinically indicated. Patients with cardiac arrest focus was performed during rhythm or pulse check, and focus view included presence or absence of cardiac arrest, identification of reversible cause such as tamponade, massive pulmonary embolization, severe hypovolemia, tension, pneumothorax. Data collection was done, and these were the performer. Statistical analysis was done, and ethical consideration was also obtained. These are the few pictures from the study. The picture showing parasternal long axis echocardiographic view showing right ventricle, left atrium, ascending aorta, descending aorta, MV and AV. And picture B showing apical four-chamber view showing RA, RV, LA and LV. The results which were obtained were tabulated, and the first table showing demographic characterization of study population. This reflects the typical population presenting with shock cardiac arrest in critical care setting. This second table represents the number and the graph on admission. Third is with respect to etiology of shock, and hypovolemic shock was the most common etiology, followed by cardiogenic and obstetric cause. Fourth table represents focus finding in cardiac arrest patient, indicating pseudo pulseless electrical activity supporting continued resuscitation efforts. Importantly, reversible cause of arrest such as tamponade, pulmonary embolism, and tension pneumothorax were directly visualized and enabling promoting life support and saving intervention. This fifth table shows impact of focus on immediate decision making, and sixth table shows the outcome of cardiac arrest patients, showing focus is highly effective bedside tool in critical care setting, enabling rapid etiology diagnosis of shock, identification of reversible cause of cardiac arrest, meaningful influence, or immediate clinical management. The discussion of the study was focus in guiding clinical decision making during management of shock and cardiac arrest in critical care setting. These findings demonstrate focus is not merely a diagnostic adjuvant, but a dynamic bedside tool for that and directly influencing the etiological diagnosis and therapeutic intervention and prognostic assessment in critical ill patient. The conclusion was the prospective observation study demonstrated POCUS being a valuable and effective bedside tool and helps in rapid etiological diagnosis of shock, enabling identification of reversible cause of cardiac arrest and significant influence immediate decision making. Its ability to differentiate true pulseless electrical activity from pseudo pulseless electrical activity and to aid for prognostic further underscores its clinical importance. When trained by or done by trained clinicians and integrated with standard resuscitation protocol without interruption of high quality cardiopulmonary resuscitation, focus enhances uh, precision in diagnosis and treatment. These are the references articles which were taken. Thank you so much. Happy Christmas. Happy New Year. शी तो कट करते आते हैं नहीं स्टॉप वो रिकॉर्डिंग बंद नहीं किया था मैंने हैप्पी क्रिसमस क्या बोल रहे थे